All right, it's almost 1:45, and so I want to go ahead and start with our next session. I want to let everyone know that CEs are available. PD AHAC is offering continuing education at no charge for this breakout session for EMS and law enforcement. For registered nurses and social workers. To receive credit, you must have attended the opening session and the healthcare breakout session 1, as well as attended the keynote speaker presentation that will be later today. See the tent card on your table for more information. You must sign in on the sign-in sheet on your table. If you have any questions during the conference about CE credit, please see Kimberly or BJ at the PD AHAC table. Now I'd like to introduce our two speakers for this session. Rob DuPont. Rob serves as the System Administrative Officer of Behavioral Health for MUSC Health. He holds a BS in Therapeutic Recreation and Master's in Healthcare Management. Rob has more than 20 years of hospital-based behavioral health experience, having started on the inpatient child and adolescent services. He's also worked with adult populations in acute, residential, and forensic settings. He's maintained a focus on program development and improving access to behavioral health services. Tim Smoke has served as Associate Vice President of McLeod Behavioral Health since 2016. He manages the day-to-day operations of a 23-bed acute inpatient behavioral health unit located in Darlington, South Carolina. He also serves as a system resource for behavioral health flow and treatment. Tim is a certified instructor for nonviolent crisis prevention, and he has received several awards for his work in the mental health field. Please welcome Rob and Tim.
We're going to see how this works. Okay, on behalf of Rob, the MUSC McLeod, I just want to thank Lynn and the Jonathan Foundation for giving us this time to share very exciting work for our region. We just appreciate the support, and we look forward to working with each one of you as community partners and stakeholders. As you can see, we're talking about the region, and just for a point of reference, we wanted to, the PD region, DHHS has identified this region in South Carolina as being one of the most underserved in terms of behavioral health care and access. I know that you, as frontline people, know that. But what I wanted to do is give a little bit of reference into where we are and where we stand. In the 2020, the state health report in 2020 from DHAC for the state. Now keep in mind, in the state of South Carolina, we're one of the most, we're in the top 3 underserved. But the state, in terms of state and national data, the 2020 report said that, found that for Darlington, Florence, and Marion counties, we could easily use 25 more inpatient beds. For Chesterfield, Dillon, and Marlborough County, an additional 21. And then for Clarendon, Lee, and Sumter, we could use another 32. And that's just inpatient. They did not factor in outpatient resource needs. The state of mental health in America scored South Carolina in the 2022 report 43rd among states for access for behavioral health. Now, the higher the number there is not good. We're 34th for percentage of adults with serious mental illness that didn't receive treatment. 44th, the percentage of adults that are underinsured or uninsured. And then 46% for those percent of youth with major depression who did not receive any treatment. And then 41st in mental health provider availability. Nearly 800,000 South Carolinians live in one of the state's 62 health professional shortage areas, and they ascertained that another 38 psychiatrists would be needed to close this gap. So we know it, we feel it every day, but that's just where we are. Go on. So the PD region, here, we know this, but current state, as Rob mentioned earlier, we have excellent community partners. We have the Department of Mental Health, we have Hope Health, we have CareSouth, and please forgive me, I don't know everyone that's represented here. So, but outpatient, you've had to be very creative in figuring out how to manage these patients. We have in this area one 23-bed adult unit. We've never served adolescents and children in terms of inpatient. We had years and years ago an intensive outpatient and partial, but that went away. So and we have substance use with Daovis, and that's represented in each county, and you can see this. But the gap, we offer extensive outpatient, and then we have minimal inpatient, but nothing in between. And as you saw Rob's presentation this morning, that wheel only represents about 30% of the continuum of care that's needed to provide care for these patients. So the Leatherman Center, we'll talk about a little bit more how we plan on fulfilling that gap, and now I'm going to turn it over to Rob to share the timeline and the work that's been done.
This part of the technical work is not our forte, but we'll try to get that part figured out. So, touched on this just briefly this morning, but wanting to talk in some more detail on the work that's gone in. Our focus here for today, we want to make sure we're highlighting on what the facility is going to do, programming more specifically in there, but also around all that collaborative work that got this to where we are. So, years ago, it really started as discussions of how do we start to address the behavioral health needs that, as Tim has mentioned, definitely are here in the area. That initial work group, including MUSC, McLeod, PD Mental Health, and Hope Health, said, well, we feel it, we know it, but let's get some of the data, let's kind of quantify what we're seeing. So they engaged a third party, Barry Dunn, to help do a gap analysis in the area, get some information from stakeholders, and look at the data to help look at that. Conducted those interviews, and then this is really small to see, but I'll give you the highlights that are there of finding that, yes, there are huge gaps in services. And so trying to look at that and say, where are the biggest needs, but then also what's the easiest to implement? Because if you say, well, we need inpatient beds, that's a huge lift. And we're doing that work now, but that takes a long time. So you say, you have a need today, what are things that you can do shorter term to be able to make an impact today? And then maybe, that's your short-term plan. Long-term, there's some other things that you can work to address. So through that gap analysis in there, really then took out a couple of things. Yes, you need inpatient, but the quicker things would be crisis stabilization and able to have some of those resources to implement, and then also around those PHP, IOP types of programs to still not easy because you need where do they go, who's going to run them, all those other aspects. But as far as having a quick impact. So there you go. There's your increased holds in those impacts. And what we talked about this morning, people get to the ED. Without those other options, it's either wait the ED, it's waiting for that inpatient bed. Sometimes that's in the area, but with very limited beds in the area, then it's often waiting for a bed outside the area. And then, as Tim mentioned too, there's really nothing for child adolescent. And talking with the schools and with other providers, that's a huge challenge. When you've got a teenager who's in crisis, the only real option is to send them to the ED, but you know they're not going to get the services that they need there. Getting to that next place for service can take much too long. It's often days and days. And as we mentioned, people often get worse in that environment. It's not the right environment, so it's not going to help with the issues that you are trying to address. As I mentioned, these key initial partners, and that's just where we started. And Circle Park has been very engaged here as well. Just at this time, in wherever that falls, 2021 still, hadn't really gotten engaged with the process yet, these initial groups to be able to do that. What really changed the focus for this group and get us to where we are today is that work through the Master Plan Advisory Committee and allocation of funds. The state came to Department of Health and Human Services and then making this a priority. I mentioned again with Hugh Leatherman and his work had been a huge mission to make sure that the services that were particularly lacking here in PD in Florence, that was finally addressed and to get the right resources in the right place. But then still through the work on this Master Plan Advisory Committee to say, where's the first place? How do we start redesigning behavioral health for the state and have an impact? And this first major step is how do we create a resource that can do that. Part of that goal came through Proviso, making sure that no one in South Carolina was further than 90 minutes from the right level of care. We show that map of those outpatient services. So those services that are there may have just geographically the ability to get there, but is it the right resource? And so that's part of what we want to do here is in that hub model is making sure that we're filling those gaps so that we can provide the services that might not be available within this part of the state. I spent most of my time in Charleston at MUSC there with our Institute of Psychiatry and can tell you that a lower number might be 10 referrals a day, a higher number is 20. We probably average 12 to 15 referrals per day for people outside of the Charleston, Tri-County area who are in need of a bed. Now, the challenge that we have, and the unfortunate thing is we have so many people in the area that are needing an inpatient stay as well, that we're pretty full. We can't take as many people from outside the area. We take as many as we can, but those referrals are coming in every day. So those are people in an ER, some are scattered anywhere across the state, who are seeking a bed, and as I said, often we're not able to take them, so they're waiting another day for a bed. Our PD advisory committee formalized, and here's our committee members. I mentioned our governance council. We'll talk a little bit more about the work happening there. One of our first major steps with our PD work group and around creating this proposal was designing the clinical framework. What are the key areas that we need to be focusing in on? We'll talk more about that as we go. Oh, here it is here. So, and it touched on this morning, so I won't spend too much time here, but that key point of what exists, what gaps are there, how do we fill in as many of those gaps as possible? And so it does come down to access, more of that crisis emergent care in short stay to be able to manage crisis in those areas, and then those outpatient and inpatient services. So clinical framework, we worked on that, presented our proposal to Department of Health and Human Services, which was written the end of 2022, beginning of 2023, and got approval for there, and then we were able to start in on our work. It's roughly, so I think it was last June when we had the official launch here in Florence to be able to really kick off that work. And so since that time has been demolition of the building. We have, to see what that looks like, but also full design of the new hospital, full floor plans layout, right down to door hardware and camera placement and all those aspects there. Parallel to that, and the work that's continuing is around our program development, and Tim will speak more to that as we move to the next part. Do you want to jump into this part? So I'm going to hand it back to Tim, and we'll continue from there.
Michael, yeah, I think so we knew we had a need. The state recognized we had a need. we had a site, but how do you go from Cedar Tower to October the 25th, opening a 63-bed inpatient, 20-bed crisis stabilization unit? That is a massive undertaking and a massive task. So, let's see, let me go, I'm just going back here. Okay, so both hospitals, McLeod and NUSC, felt it would be valuable to get an external partner with skills and expertise in project management. So Knowledge Capital Group was hired. They have experience with large-scale organizational transformation, and so they are helping us facilitate all the development of our clinical operational skill programs, sharing with us project management best practices, how we organize that, because the information task, I think we had like 30,000 tasks that was related to this project. And then just communication. Our Donna Iskett, our CEO, likes to say we're better together. Two brains are better than one. I teach crisis stabilization and crucial conversations. One of the things about crucial conversations you hear, the shared meaning, the more people that can have input, the better the information, the better the decision. So we identified early on, for this project to be successful, we needed to start with the right people and continue to add people for the success of this. So you can see our community partners, Cloud, NUSC, DHHS, DMH, Hope Health, Care South. These are the council's focus. I won't get into that, but strategic planning. How do we make this successful? How do we identify risk? How do we accomplish barriers or overcome barriers? Community engagement. How do we involve everybody? That work has already begun and will continue. So where are we? Rob showed you the slides. They're already out of date. This work is fast moving. Steel, we signed the steel bid today. My understanding is the last of the steel is supposed to be done by the end of May, and then we will be progressing through. Completion plan is for June 2025 with opening in October of 2025. And so far, we're on schedule. Just pictures there, current state. I think that was taken last week. It may be a little more progressed. So the work, future state. What is it going to take to get us to this place? Now, through the work with Knowledge Capital, we have 7 work streams and 33 different work groups that encompass everything from design, construction, human resources, recruitment, quality, finance, marketing, and then you have the clinical delivery side, which includes your nursing, lab, radiology, ancillary, social work, all of those things. And how we're working that is you have weekly meetings of these work groups with the knowledge experts, content experts. They report up to the workstream owners, who then report up to the executive steering committee, so that we can identify risk, we can identify progress, we can identify where we are and what needs to happen. It's interesting for those native to the PD. You know, I've been on Dargan Street, I can't tell you how many times, and seen Cedar Towers, but had no idea once it was cleared off the massive lot. That lot represents 13 acres of land, and the building, I think the last square footage count was 105,000 square feet. So that's going to be, and for me, and many of you, downtown Florence revitalization has been such a long overdue need for our community, and to have a behavioral health center now adding to the beauty of the downtown, to me, is just, it speaks volumes. So here's, I wanted to share a little bit about that. It's going to be hard because I don't have a pointer. So One of the things that's been so wonderful about this project is we've employed Array Design and Contractor Company, and they're experts in mental health building design. Mental health, as you know, those buildings have to be designed with patient safety in mind, and you have to be very strategic and very, very careful, and you have to take into account patient flow. So we had 5 full-day design meetings with 50 plus key stakeholders. We dreamed big and then had to scale back a little bit, but even the scaling back, we took into account patient safety, patient flow. That was never sacrificed. So this is the floor plan that we've landed on. Again, now we're going to be offering the full array of services. So intake, our vision is to reteach our community, you don't have to go to the emergency room. You can come here. So that intake center, you can see that access center, 4 assessment rooms, 2 medical exam rooms. The whole design has strategically separated adolescent and adult for safety reasons. It's just best practice. But so that dark green that you see, that's your intake area, and then around that, if you look to the immediate right, that's going to be the adult crisis stabilization unit, and then to the left is adolescent. And then coming straight down, and then that entrance will be where the majority of our patients that will come from hospitals. You know, there's a need for privacy. There's a need for dignity, there's a need for safety, so that will be a very secure and private entrance. If you flip coming down to the others, just straight down, that's going to be the main entrance for patients or individuals that want to come in voluntarily seeking services. They'll come in and then they'll go through the same intake process. Immediately to the left of that, in that slightly brighter orange, that's going to be our outpatient, which is our intensive outpatient, and IOP and partial for both adolescents and adults. Our goal is to build a program that can support 12, average daily census of 12 in both programs. All right, and then you go, so then you can see in the blue T's, that's our inpatient units. If you look directly coming from the main entrance, you see that inverted T, that's going to be our adolescent unit, 12 beds. And then if you see the two T's at the top, that's going to be 2 adult units. Those are 2 20-bed units, and we're going to separate out by patient need there. And am I missing it? Okay, so the GME, okay, yeah, thanks. The GME, that space, that's purple. That's personally one area that I'm excited about. Florence the PD is, for a variety of reasons, it's just a hard to recruit area. And I'm truly optimistic that the NUSC influence with the residency program will provide incentives for residents to come, to train, and to stay. But that's in the purple. Super underimposed there is the acute unit, the 11-bed acute unit. You can't see it, but it's laid out just like in a T, just like that. And then you can see the green, there's going to be outdoor rec spaces, and then lots of opportunities for recreational therapy and things like that. So this facility will represent 63 inpatient beds and 12 adolescent beds. Okay, so what are we learning? We learn every day. Engage the right partners. If you don't have the right people at the table, you limit your success. And we've started with stakeholders. We're going to continually add, and as we get closer to the work, then we'll even add more. A robust project management structure and tools, that's been a huge learning curve for most of us. But with the influence of Knowledge Capital, their support, we're learning that, and we are making that work to work through the work that needs to be done to get to our opening. High levels of communication, transparency, that goes without saying. We're communicating, we're reporting up, we're reporting to our community partners, and I'm reporting to the McLeod folks. Rob's reporting to the MUE, so that we're all working together and we're transparent. Learning from others. It's really exciting for me to be able to work with the MUSC folks that do IOP because they do have a good product. And I'm excited about this coming to our community. That being said, McLeod has a good product as well, and we're sharing ideas, and I've been really impressed with the collaboration with how it's going thus far. Being strategic, ways to efficiently use limited resources, that's a concern. We have areas, our patients generally have very limited resources. And how do we meet their needs? Just opening up a 63-bed hospital is not going to solve the problem. It's just one piece of the pie. And then always keeping an eye on the future. We got to, if we're not constantly changing, we're already behind the eight ball. So what do we need to do to make this successful? All right. And that being said, the space may not be as conducive, but we just want to open it up for some questions and answers. And any thoughts, questions? So the question was, will this hospital serve just patients in this area, or will it be open to the state? It will be a regional hospital. Priority will be given to patients in this region, but absolutely we would serve patients from all over the state. This is the first of 3 regional hubs. Hopefully, we're under a lot of pressure because they're looking to see how successful we are, so help us make it work. But as we grow more, then there will be more resources. But at this point, it is a regional priority here. But yes, the whole state.
And we can still take questions as well. Tim walked me through all of the plans here. I'll touch a little bit on that programming too, for some of those spaces, so you can see all the detail of where we're going to specialize the different services that are in there. I think a couple of parts as we start getting into that day-to-day programming and what that looks like. Of course, the training being a huge component, so we know we'll have students, med students, residents, and is that component. For those core teams, it's certainly with physicians, nurse practitioners, PAs, licensed social workers, nurses, and behavioral health techs, running that team of the programming and everything that we can do. The way that these units are set up, that within that contained unit, each one has its own dining area. So meals coming in and being able to have a designated dining room. Also with having a group room for more noisy activity or group rooms that way. Also quiet activity, calming rooms, and then a common area out in the main area of the unit as well. So multiple spaces on the unit for people to be out of their rooms, have multiple spaces to have separate programming within there. Also voluntary calming space that will be designed with more rocking chairs and more comforting kinds of items to be able to separate out from the milieu and from the other people on the unit and have that opportunity. In between the 2 larger T's on the top, that kind of middle section, not only do we have an outdoor courtyard that is contained there in that space, but then also a gym, and so we'll have gym equipment and active space to be able to do programming in there. And then next to that has a larger art and activity room to be able to do lots of different things in there. So not only the things that we'll be able to do on the unit, but then being able to pull patients off of the unit as well for some of those larger and more specialized types of programming that we could do in those spaces. Mentioned this morning that we want to make sure that all those same resources were available for the pediatric population, but separate from the adults. And so in that bottom-ish left side, all of that space is dedicated for pediatrics, being their own courtyard and outdoor space, their own We designed it right now with less gym equipment, but more of an open space for that physical activity, lots of different kinds of programming that we can do in there, but making sure that physical activity is incorporated into that daily program. And then also a larger room for that arts, crafts, art, the different things that can happen in that space, in addition to all those same kinds of spaces that they have on the unit. So not only having a diverse treatment team that we can provide those specializations through the team that's there, but multiple areas on the unit and off the unit to be able to provide an array of services that way as well. Some of the things that we do in our facilities now, and will certainly be incorporated, is where we bring any community members in to be able to do additional programming. So often that is AA and NA meetings, can be, depending upon the resources of the area, NAMI support groups and presentations and different things that can happen. And so nothing that's been established yet, but as we look at our programming, that'll definitely be a part of it too, where we can have community partners that can come in on site and be able to provide some of that as well. Yeah, so if you couldn't hear the questions, October 2025 is the targeted date. We want to be able to open. We won't be able to necessarily open day one with everything in place. What's the plan for there? The goal is to open as much as we can as possible. We don't want to restrict that, but realistically being able to hire in enough staff and the whole team to be able to fully operationalize the entire hospital on day one is just probably more than a lift than is truly realistic. So we're trying to map out what is some of that growth in that plan there, and then trying to prioritize from there. But again, as much as we can open, that's what we want to have day one, and then it'll be a continued focus until we're fully operational and have every program in place. I know as we talk about some of those priorities is where we go from services that don't exist to being able to add those in. My own personal, I know we don't have any of those child adolescent types of services. I want to really focus to make sure that we can get at least part of that started day one, because I think that's a huge area that's being missed. But at the same time, knowing the beds that do exist in Darlington and the facility there at 23, that 23 we want to be as high above that as we can right from the start. But realistically, I mean, that growth plan is part of it. Is where's our target? Where the hiring kind of growth plans to be able to hit the initial target. And then be able to just build it as quickly as we can from there, and it'll be a continued focus until we can get to that full facility. I'll take any other questions, Senate.
Well, thank you for your time. Appreciate it. More to come.
Yeah.
Jane.